Here we see the instrumentation developed to treat a Hill-Sachs lesion, the benefit being recreation of the normal anatomy while repairing a Bankart lesion, with the hopes of reducing the recurrence risk by decreasing the amount of bone loss on the humeral head. As part of this kit, we've got a 2.4 millimeter drill that you're going to use to localize the Hill-Sachs lesion, and that can be done using a combination of arthroscopy as well as intraoperative fluoroscopy. After you place the guide wire in the appropriate position into the Hill-Sachs lesion, which is typically the posterior lateral aspect of the humeral head, the kit comes with a 5 millimeter reamer that you're going to use to ream over the guide wire. And once you've reamed your path, we also have this 1.1 millimeter guide wire that you're going to place after you remove the reamer to hold the place while we assemble the decompression tool. What we also have here is the decompression tool and its associated bender, which allows you to adjust the bend that the tool comes with, which allows you to really access any Hill-Sachs lesion. Once you've tamped up the lesion with the decompression tool, we're going to then want to backfill the lesion. And I prefer a calcium phosphate backfill. We've done significant research on that, and it provides structural support, but also has collagen in it to allow for some biologic activity as well. And I prefer to use the BoneSync backfill because it's quick setting, typically sets in about 5 to 7 minutes. And as I mentioned, there is a collagen component to it, so there is some biologic advantages to it as well. This is a 25-year-old male who suffered an anterior shoulder dislocation, indicated for surgery based on their history, exam, and MRI findings. The MRI, you see a representative slice of an axial image showing the anterior Bankart lesion, but also the Hill-Sachs lesion at the posterior lateral aspect of the humeral head. On the x-ray, we see the Hill-Sachs lesion as well. The theory here is that if we can obviously treat the Bankart lesion arthroscopically, which we've got very good success doing, but also restore the anatomy of the humeral head, that's going to decrease the risk of future recurrence after an arthroscopic stabilization. So you would do your standard arthroscopic Bankart repair, and once that's completed, we would turn our attention to addressing the Hill-Sachs lesion. In the joint now, you can assume that the arthroscopic Bankart portion of the procedure has been completed, and now we'll turn our attention to the Hill-Sachs lesion. This is a cadaver model. There is no Hill-Sachs lesion, but I'm using a 70-degree scope from the posterior portal. This is where you would typically see your Hill-Sachs lesion. There's the normal bare area with the infraspinatus at the top of the screen, then the bare area, then the humeral head, and this is where you would typically see your Hill-Sachs lesion. Now we're in the subacromial space, so we're going to be posterior to the bicipital groove, about 1 centimeter to 1.5 centimeters distal to the greater tuberosity for our entry point with the 2.4 pin, after which we'll ream with a 5 millimeter reamer, and then obviously hold our place with a 1.1 millimeter guide wire. I've highlighted some relevant landmarks here. Here's the lateral aspect of our acromion. This would be the lateral aspect of our greater tuberosity. The axillary nerve is crossing distal to that. And here's our bicipital groove with the long head of the biceps in it. For this procedure, we want to be posterior to the biceps and just distal to the greater tuberosity. So somewhere in here is going to give us a pretty good angle to get to the posterior lateral aspect of the humeral head to reduce the Hill-Sachs lesion. So this is, about 1.5 centimeters to 1.5 centimeters distal to the greater tuberosity. We're posterior to the bicipital groove. This cadaver does not have a Hill-Sachs lesion, but this is where you would typically see it. So we've got the starting wire in place, and now over this, we're going to ream with a 5 millimeter reamer. Good. Once the reamer's in place, I've now kind of reamed under the Hill-Sachs lesion where it'd be. I'm going to uncouple it from the drill because it is cannulated. So we'll take out the starting guide wire. And then I'm going to use the 1.1 millimeter sort of wire holder just to hold our space while I assemble the decompression tool. So before backing out the reamer, I'm just going to confirm that the wire is in place. And then I'll just back out the reamer. Now I've got the decompression tool, which is cannulated. Once we remove the inner tube, it's going to slide over our guide wire. Once that's in place, I'll remove the guide wire, and then we can reassemble the decompression tool Make sure that your tube is bottomed out, and then it's a 90-degree twist, and now it's assembled. Now I can use a mallet to tamp up the impression fracture or the Hill-Sachs lesion. Mallet it up to decompress the fracture. And once it's in place and we've decompressed the fracture, I like to back it out a millimeter or two, just to allow some room for the BoneSync to backfill the lesion. With the decompression tool in place, I'm going to, again, uncouple the inner tube, and now I'm going to insert the BoneSync. So here's the BoneSync assembled on the back table in the syringe, and it fits nicely right on the lower lock from the decompression tool. Just going to twist it in. It's a spindle, so I'm just going to twist it to fill it. On the floor, you can actually see it's radio opaque where the BoneSync is, so it's easy to see it going in. And then in real life, where you've got the Hill-Sachs lesion, where you've got a big void, it's even easier. I typically will just close up my portals at this point, and then it's my standard postoperative rehab protocol that I would use for any anterior stabilization.